Good afternoon, everybody. We have Dr. David Woolner here for Grand Rounds today. He is the Director of Palliative Care with Barnabas Health Medical System. He has loads of experience and is a wonderful palliative care physician, and he will be talking to us about current topics in palliative care, right?
Thank you very much. Good afternoon. I thank you for your introduction, Seema. I certainly thank all of you for the invitation to come here, and I'm sort of a nice day off from work. And I'm glad you brought the sun for us today, too. What I'm going to talk about is current topics in palliative care. I'm going to cover a large number of topics, so I prefer leaving questions to the end so that I can get to a fairly large volume of information. I have no conflicts of interest. And these are the robust educational goals, and we'll zip through them quickly. There are 8. The last one is to support the role of research in palliative care. And what I'll do is, through the different topics, is emphasize how research is involved. I'll begin very simply with the definition of palliative care, because I think this is the commonest question I'm sure Seema and I get when we make rounds. And this is a definition that was developed by the National Quality Forum, and it's the definition that we use in this country. And palliative care is patient and family-centered care. It optimizes quality of life by anticipating, preventing, and treating suffering through the continuum of illness. It involves addressing physical, emotional, social, spiritual needs while facilitating patient autonomy, access to information, and choice. I take the time to read that because each time I read it, this is what we've all been trained to do. It's nothing special. This is the mission that doctors are trained, and palliative care is just an example of what we all do as physicians. So when people ask us what we do, we give them the definition, but we basically say we're to work with your primary team to help things out. Palliative care is not just for the imminently dying. Again, that's a common misconception. So palliative care can be integrated from early in the diagnosis of serious illness to the very end. And usually palliative care models, certainly hospice, incorporates bereavement in the clinical package. This is a colorful slide to let you know we work in an interdisciplinary way. We usually work commonly with a physician, a nurse practitioner, psychologist, medical students and interns, but also a chaplain, someone from volunteer, someone from pharmacy. So it's a multifaceted approach. And although physicians are part of the team, they're not at the top of a hierarchy. It's a team that works in an interdisciplinary way in the same planar level. This was published just a month ago in the journal Palliative Medicine, and a large number of Americans were polled about what their knowledge is of palliative care, and 71% throughout the country really had no idea what it was about. And when they looked at which people knew more and less, it ended up people who had college educations, that were older and that were white, had more of an understanding than other people. But it clearly shows that there's still a clear lack of understanding, not only in the medical community, but in the general community, as to what the dimensions of palliative care are. Sometimes the word comfort care comes up. I don't know if you've heard it, but to me, it's another thing that can be more confusing than not. So if you look at the right, a paper was produced, published in the New England Journal about 3 years ago about using comfort care for the imminently dying inpatient. And it makes a good argument to change care plans and aim for comfort. On the other side is a more recent blog saying that comfort is what we do anyhow. And if you remember the aphorism about curing at times, helping often, but always comforting is the main dictum. So again, the principles of palliative care, the terms we use, are no different from what any physician or team does in the hospital. I'm going to move to 3 areas in the ethical arena. And this was a headline I read just a few weeks ago in the New Jersey paper. And New Jersey passed a law It's one of 6 states in this country that passed a law, and in this state they call it Aid in Dying for Terminally Ill Act. And Governor Murphy is going to be signing this. And I'd like to read his quote of what he said when the bill was passed. He said, allowing terminally ill and dying residents the dignity to make end-of-life decisions according to their own consciousness is the right thing to do, and I look forward to signing the law. And this is the basic thing of what the law is, and I don't want you to read all this, but to realize how many hoops and hurdles you have to go over to, in a sense, be eligible for getting assistance in dying. You have to be a resident older than 18. You have to be of clear mind. And one of the interesting things is you have to be able, if you choose to take your life, to be able to do it yourself. And we know commonly in advanced disease, as the end of life approaches, people lose their mental clarity and many times their dexterity for doing it. Oregon was the first state to legalize physician-assisted suicide. They kept very meticulous data, and we can see over the last 20 years the number of people requesting assistance in suicide has increased, and also the number actually completing suicide has increased, but to a lesser proportion. And if we look at the Netherlands, where euthanasia is not legal, but is done, the curve is very similar over the past years. In the Netherlands, most people have advanced cancer, and what we can see in this interesting graph, if you look at the green top curve, 80% of people in the Netherlands who do take their life do that at home. A very small amount occur in hospitals, a small but increasing number occur in hospices. So what is this all about? Is this the latest thing palliative care does? I'd like to read a quote from Judge Rehnquist. This was a Supreme Court decision 20 years ago when a New York physician petitioned the court requesting legalization of physician assistance in suicide. The court said, and this was a unanimous decision, the question shouldn't be whether the state has an interest in allowing a person to ask a doctor to help them commit suicide, but whether the state has an interest in helping citizens live the last days of their lives comfortably with as much dignity as possible. And I think this says it all. It's a clear underwriting of the principles of palliative care in caring for people with serious illness, but not assisting suicide. The European Association of Palliative Care put out a white paper, which was an academically produced, cited article with many experts, and here's what their conclusion is. The provision of euthanasia in palliative care should not be included in the practice of palliative care. Palliative care is provided to the very end of life. And the very last thing, again, gets back to the comfort, that we're here following the principle of non-abandonment. So when the tough time comes and people reach the end of lives, it's important for us to be there. So what I'm trying to show you is both in the US and certainly in Europe, there's no underwriting of physician-assisted suicide as a legitimate medical practice for our societies. Okay. The second ethical area is the opioid epidemic. I don't think any of us could have imagined 30 years ago that we'd be reading daily news about the number of people who are dying from opioid overdoses in this country. Right now it's tacked at 70,000, and this is actually going to increase before the epidemic is controlled. Another striking thing is the distribution. The red areas show higher incidence of death from opioid overdoses to others. And this relates to very interesting patterns about how drugs are distributed in this country. A workshop was held earlier this year about dealing with opioids and chronic pain. And the only thing this graph shows you that's important, that fentanyl is clear and away the most common opioid that's used that causes overdoses in this country. And not only fentanyl alone, there are other relatives of fentanyl, like alfentanil and sufentanil, that are also used. So fentanyl is clear and away the commonest drug that causes an overdose opioid death. This is a quote from the DEA. Fentanyl is the most significant opioid threat and poses the greatest threat to opioid users in the United States. And this is true, and it's wise. The DEA are not our adversaries. The DEA are our friends, and they're saying what's very true, that fentanyl, a drug which we use commonly in palliative care, is the major cause of this epidemic. An article just a week ago in the New England Journal, and I'll read the title of it, Preying on Prescribers and Their Patients, Pharmaceutical Marking, Iatrogenic Epidemics, and the Sackler Legacy. This is really just unfolding, and it's not clear legally, but there's really good evidence to suspect that there was almost a conspiracy with pushing and overestimating the safety of opioids. The interesting thing about this article is that the patriarch of the Sackler family, which basically produces MS-Contin and OxyContin, did the same thing in the 50s with a tetracycline derivative. He invented a tetracycline isomer that was no different than any of the others that were on the market, but marketed as the latest and greatest. Made a huge amount of money for Pfizer. So we're saying that business interests certainly do play a role that we have to be appreciative of in how medicines are marketed and used. 2 weeks ago, this was the president of INSYS, as a producer of a medication called Suboxone, which is an oral preparation of fentanyl. He was convicted along with another leader of this group of racketeering and basically choreographing a well-designed crime scene of pushing a drug that was not necessarily effective and pushing the reps to overutilize it. This man will be in jail for a long time, and I think as the details of how this epidemic evolved, we'll be seeing more criminal acts that have occurred. But this has led to a backlash. We know now the CDC has guidelines for all of us about how to use opioids now, certainly in hospitalized patients. But Dr. Barrera, who's the head of palliative care at MD Anderson, one of the largest and older programs in the country, is saying we're getting problems too. So there's the lack of availability of parenteral opioids. And what he cites is that the different options that we have right now put a lot of pressure on the systems to give good pain control for sick people. And the final area is in the area of ethics would be advanced directives. And PULSE is an advanced directive, a model of an advanced directive form that is used defining physician options for life-saving treatment. And is that a program you use here? I see a few nods. It's really quite good. The unique thing about PULSE, it allows a physician or NP and a patient and family to get together, not in the days or weeks before the end of life, but when illness is progressing, and allows you to hear what patient preferences are. And the PULSE allows you to make sort of a detailed outline of the things you don't want to do or don't want to have. So DNR is a common choice that may be selected, but there are other things, for example, about the use of blood products, the use of artificial feeding. Should there be any more diagnostic testing? Should a patient be admitted to a hospital? This can all be discussed, codified in this one-page form, signed by a doc or NP, the patient, and a witness. This becomes a legal document. It's a portable document that goes from the hospital to home, home back to the hospital, hospital to nursing home, and so on. And the other thing is a validated order sheet. So when this green form or a copy of it is on the sheet, and it says patient has elected not to accept CPR, that immediately is an order that you're not going to do. You don't need an order for CPR. A colleague of ours in Princeton, David Burrill, is a geriatrician. He's developed a net-based approach to using PULSE. And in a geriatric center, he's done a randomized study, actually. The numbers are not that important, but what he's shown is that people who've been engaged in working on a PULSE form before they're very near the end of life eventually cost less money near the end of life than those who don't get involved with advanced directives. This doesn't mean that you're doing an advanced directive just to save money, but what I think the advanced directives do, it allows discussion to find what people would like or what they would not like, and avoiding unnecessary diagnostic or therapeutic means. And also here in New Jersey, this is a grassroots approach that's just been started. It's called a 4-step eye care plan. But what this basically is a grassroots development of people and organizations getting together to educate the public so that the public can go to this group's website and be instructed into what advanced directives are, how to do a pulse, how to download a pulse, and how to bring it to your physician. And I think in terms of the quagmire of advanced directives and so on, that it's going to be these community-based grassroots approaches that are going to be more successful than what we could do alone in the hospital. Okay. Well, I talked about the bad things of opioids, but I want to reemphasize the good things. Opioids are still the standard analgesic for severe pain and advanced disease. This doesn't mean cancer alone. It can be what the opioids are, how they work, what some of the newer developments are. It's important to understand what research is being done, and now there's a tendency to look for non-opioid analgesics, and I'll be curious to see what evolves from there. It's also important for us to know the laws of how opioids should be prescribed legally. And in the end, we have to have a balanced approach. And looking at the principle of dual effect, we always have to weigh the pluses and minuses. I think the most important thing for us is having avoided doing a screening for risk of opioid abuse. And again, there are adverse effects by underutilizing opioids. And what we've seen in the chronic pain community, where people have been managed at times for years on around the clock and PRN opioids, that they're having more difficulty getting it. And this has sort of spiraled down into a situation of what's called pseudo-addiction, where people are beginning to hoard or beginning to worry where they're going to get their medicines. So people who've been managed for a while on opioids chronically are suddenly at risk of decompensating because of the difficulty in opioid prescription and obtaining. This is the tool I mentioned. It's one of many, but it's a good thing to have. It's 4 questions, and you can really gauge whether the person you're seeing is at risk for abuse, opioid abuse. And if that proves to be the case, you talk about it honestly, and you deal with an addictionologist to help get through that particular problem. And this is something that can be done not only during your initial evaluation, but periodically whenever you're reassessing pain. It's important to remember that milligrams of one opioid are not equal to milligrams of another. And I think the most valuable calculator we use is a pen and pencil, is to realize that there are different degrees of potency, and there are also different ratios of converting from an oral to an IV approach. So whenever you're going to select or change opioids for your patients, get out your pencil, get out your paper, and convert all the opioid dosing to what are called morphine equivalents. And this is just one example of how to do that. People commonly say, well, you know, my family member is sick, won't the opioids kill him? Or commonly there's a myth that hospice is solely for using opioids to take a patient's life. And this is a study from Britain that looked at people with cancer getting different doses of opioids. They were divided into lower dose and higher dose. And you can see survival over time is virtually the same. So opioids, when used safely in sick and frail people, can give adequate pain relief without any, let's say, undue risk of fatality. I'll get back to fentanyl. I'll discuss 4 medications. Fentanyl is one of the more important opioids added to our regimens. The 2 structures below are alfentanil and sufentanil. These are opioids that are more potent and more rapid acting. And you're all familiar with the fentanyl patch, which has been used for about 30 years. It comes in 4 different strengths. It's a wonderful drug in all populations. The most important thing to remember is you never start a fentanyl patch when you have an acute pain crisis. Use another opioid, an immediate release opioid, to determine what the patient's need is. Then you can convert using a table to a fentanyl patch. One of the common mistakes we've seen, for example, I don't want to pick on house staff alone, but commonly someone will come in with severe pain and a patch will be put on. The next day in rounds, pain really isn't better, another patch is put on. The important thing to remember is that the fentanyl is absorbed slowly and doesn't really peak until about 18 hours, and it can reside in the blood for about 2 or 3 days thereafter. So again, the fentanyl patch is used only for sustained release purposes. But there are 4 preparations of immediate release fentanyl. The one on the left you're most familiar with is the fentanyl lozenge. The 2 in the center is one is an effervescent pill, sort of an Alka-Seltzer, and the other is a buccal patch. And at the end is a nasal spray, which has been used more recently. So here we have a well-studied, potent opioid that is effective for all people with serious pain conditions from advanced disease. And it has its PRN counterpart, in other words, the immediate release form for dealing with breakthrough pain. Has anyone seen this movie, Reefer Madness? I look, all the guys with gray hair. So anyone else seen it? Well, I saw when I was in high school, and it was produced by what was then the DEA in 1932. It was a B film, and it was to show that marijuana causes depravity, murder, and wanton sex. And it's really a frightening, frightening bill. For many years, this was shown, and this is what our understanding was. Now, a day doesn't go by where we hear about what's being sold in New Jersey of medical marijuana. Very confusing picture to me, but there's a big history about the word and the use of marijuana. But I'd like to say in New Jersey, physicians can be credentialed to use marijuana preparations, and it's used for people who have resistant symptoms, for example, seizures, used for chronic pain, PTSD. One reason is terminal illness. But what are the true facts? What are the scientific facts about the use of cannabis and marijuana medically? So they're effective antiemetics for emetogenic chemotherapy. There's no doubt about it, as a first, second, or third line agent. People who have persistent pain, again, these are people who usually aren't medically sick, but have had multiple back surgeries, for example, have been in a car accident with a lot of injury, that it does reduce the intensity of pain symptoms. It may improve the symptoms of spasticity and multiple sclerosis, but the conclusion is that the evidence for these 3 is relatively moderate. But for all others, there's really no good science, for example, for PTSD and so on. So to be aware that there's a lot of talk about marijuana, about all of its pluses and minuses, but be wary that the medical information to support its use is relatively sparse. Psychologically, people who use cannabis chronically are at an increased risk of schizophrenia. People who have bipolar disorders can have an exacerbation of their symptoms. Heavy cannabis users, like the Harold and Kumar type, they're at risk, high risk for suicide. And those who use regular cannabis at risk of developing social anxiety disorder. So although it seems that cannabis is being pushed for everything, it's important to be aware of these negative consequences. Ketamine is an intravenous anesthetic. It's been used for many years, and it's used commonly to induce anesthesia. It's called the dissociative agent, so people, in a sense, may be awake, but their brain is separated from their body. It's a strange thing to describe, but it's safe when used by anesthesiologists, of course. But where does it fit into palliative care? And I think we can say, with all that's being discussed and talked, the only clear position that ketamine has in palliative care is as a third-line therapy for people with refractory neuropathic pain syndromes. So it's really done for a small minority of patients. And also there are side effects. And we've seen, especially in the older population, that the psychotic side effects of ketamine are reasonably common. But just recently, an isomer of ketamine has been released as a nasal spray used for treating depression. This is the most remarkable story in that in people who have chronic refractory depression, in which standard therapies have not worked, there's no doubt that ketamine is helpful in relieving that situation. This is out of the palliative care world, but there's no doubt that the science shows that it works. And this is data from Colombia that shows by giving intravenous doses of ketamine versus placebo, that over time, on the short term, there's a reduction of psychologic distress and symptoms. So again, getting back to what does this all mean, all this talk about ketamine, and I'll just read the last highlighted sentence, which says future research is needed to address the unanswered questions. So again, it's an exciting development. I think it will require study. I think for the purposes of palliative care, just keeping ketamine in that armamentarium for refractory neuropathic pain is the best thing we can do. Psilocybin is an hallucinogen, and I'm going to mix this and LSD because both are hallucinogens and both are Category 1 drugs. In other words, the DEA bans the use of these drugs. It's thought to be a drug without any use at all. But anyhow, psilocybin, which comes from mushrooms, has been studied both at NYU and Johns Hopkins. And when used in a low-dose, controlled way, people who are at the end of life with advanced cancer do feel a benefit, especially those who have what's termed existential suffering. I put to the right just a bit of art. If you remember in the 60s, a whole avalanche of psychedelic art was coming out, and this is what stimulated it. So again, there's initial studies that in controlled settings, in studies that psilocybin is effective, and the same is true for LSD. In 2007, a pharmacologist said that LSD should be allowed to be used because it's less dangerous than nicotine and tobacco. And a leader in our field, RWJBarnabas, has looked at what's been produced in just recent years about the use of hallucinogens in medical care. And he says, given the prevalence of persistent suffering and the growing acceptance of physician-assisted suicide as a medical response, it's time to revisit the legitimate use of psychedelics. This is not to say you go out and use it, but I think it's time to open the questions and do some science about it. Okay, I'm going to move to the medical humanities. The medical humanities are very important for teaching, they're very important for therapy, and they're very important for us. And I'll go through a number of areas. Rita Sharon heads the Division of Narrative Medicine at Columbia. She was a family practitioner at Montefiore, then did a doctorate in literature, and started 20 years ago a distinct academic program that looks at narrative medicine for both education and treatment. Again, I'll read her words. Through systematic and rigorous training in such narrative skills as close reading, reflective writing, and authentic discourse with patients, physicians, and medical students can improve the care of individual patients, commitment to their own health and fulfillment, care of their colleagues, and continued fidelity of medicine's ideals. This is very true, and I think we're at a stage where, at least from what I can see with the use of the EMR, pressure to do more patients, we're losing this part of medicine, to literally discuss, empathize with patients, but empathize among ourselves. So as an example, they have grand rounds, and the one coming up this fall will be Music and the Brain, how our lives and sound who we are. And then getting back to the research, you know, it's always good to do nice things, but here's some esoteric research that does show that people who do learn and express compassion have functional MRI signatures compared to other people who don't. Hey. Wilma Balkin is in medical oncology. She trained in the 60s under David Karnofsky and had always been an artist. She retired at a younger age to be with her husband and started painting. She's done a series of watercolor portraits. On the left is a Holocaust survivor. On the right is a man who's surviving AIDS. And she does a series of these paintings. They've been shown around the country, but they're used in medical schools as teaching tools. The most important thing that we've seen here is not only beautiful art, but Wilma sits down with each person and they go through a history. They do a narrative approach. They look at photographs so that when she does the portrait, she hopes to capture who that person is. And the people who are the so-called subjects enjoy it, but she's had an immense personal growth from doing this particular art. And she was up at Montefiore just a week or two ago, meeting with the staff of the palliative care team. And it's hard to see, but these people have paintings of faces. These are masks. And she asked people to paint what they see themselves as. Again, it's just a way of opening up discussion to discuss the more personal doings of us as professionals. She has also, I'll mention, at Columbia in the Children's Hospital, an area called Wilma's Studio or Wilma's Place. And these are the kids who are in for marrow transplants and so on, who can come at their leisure and get involved with painting and other arts to make their stay a little more enjoyable. And the frail elderly can benefit from art too. This is a lady in Moravia who's quite debilitated, but paints these beautiful murals. So art, elderly, frailty, and of life fit in very, very well. This is the last, I think, art thing, but an important one. William Hunter Mullen was a portrait painter in England, and a very good one. He developed Alzheimer's disease, but wanted to track, using his art, the course of his Alzheimer's disease. So the very first drawing is when he was young and quite vibrant, but each painting thereafter was his self-portrait of himself. And I think what it shows is, in a metaphor, what Alzheimer's does to people. It was helpful for this man and his wife to do this. Again, this is useful as teaching, but I think it provides for us a visual way that words might not do of what Alzheimer's does to a person's brain. Again, getting to research, this is an open-ended study of people in England with hematologic malignancies. And they had the option of meeting with local artists to paint. But they did some metrics, and they found out that people who chose to do this during their care for hematologic disease had better improvement of their psychologic symptoms and would want to continue it. And dancing too. I found out this fellow is a relative of mine, which is why I show this here. But he directs the movement disorder area at SUNY Downstate. His wife is a social worker. And they said, well, why don't we try dance? And eventually they tried dance using a choreographer in Brooklyn and found out it was very helpful. And at Columbia and in Brooklyn and a number of other places in this country now, there are dance people who go to people with Parkinson's disease of all stages to help them move a bit. And I can tell you personally, I have a dear friend who's frozen with Parkinson's disease. For the last 2 years, she's been doing it and enjoys being picked up, going to work, and enjoying the socialization of this particular thing. And a researcher, and getting back to research is an important thing in our work, in Helsinki was able to show that dancers have a specific part of the brain that is activated when they're watching their work. So again, there's a link, we'll say, between neurophysiology and a clinical condition. Okay. And before I leave, this is just published in University of Colorado, I believe. There's a very detailed program of using the humanities for pediatrics in the hospital there for young kids. And they said, well, why don't we try it on ourselves? And they applied for grants, and they got a number of grants, including NIH, where they're now developing a program using the arts to help retain staff. They're looking specifically at intensive care unit nurses. And even people who are deeply disabled neurologically, nature can be more powerful than any medication. So again, in the people we see and the people we care for, it's always remember the humanistic side of caring. It's not always a pill, but it's a pill and something else. Okay, moving on to tools. We have a huge number of tools in palliative care, looking at different symptoms or syndromes. I'm going to mention three that are simple and very, very useful. The first is the Palliative Care Performance Scale. And this is a scale, it's quantitative, from 0 to 100. And it basically looks at a patient's level of consciousness, their degree of activity, whether they're eating or not, or whether they need help with things. And the most important thing about this is that there's a very good correlation between a lower number and a worse prognosis. So by using this tool, you can have on your chart an ongoing metric that tells you what's happening to a patient. The Abbey Pain Scale is used for assessing pain in people who are incapacitated, more commonly people with dementing illnesses. It's very common for us to hear on rounds about the older folks we see and saying, does this person have pain? And a common response is, well, they don't tell us they have pain, or they don't show it. But what this Abbey Pain Scale does is by looking at 6 different areas, you're able to determine without using language whether a person has a pain and how serious it is, and instituting, again, hopefully treatment for that. We just saw a week before last a woman who was quite frail and elderly. She had serious cardiac disease, had had a number of falls, and came in with acute cholecystitis and was too sick to be operated on. So the question was to treat her with analgesics. And we went on rounds and we asked the team, well, does she have any pain? They said, no, she's quiet, she's not doing anything. And it was very clear by looking at these different parameters, certainly facial grimacing. In her case, she had become immobile, is a good indication that there's pain. And you can clearly be confident in using some analgesic regimen for that. Spirituality is an important part of our assessment. A tool was developed by Christina Pucalki at the George Washington University. This is a 4-question tool to get in when you see your patient for your initial assessment, to understand not just about their religion, although that's a common reason, but to find out what gives them the will to live, so to speak. The 4 questions you can ask your patient is, what is your faith? Most commonly people say, a religion. I'm a Coptic Christian. How important is that to you? Some people say, well, I stopped going to church, but no, I go every Sunday to Mass. What is your spiritual or religious community? And again, more commonly, what is your congregation? But for other things, it can be social communities. And what's been very interesting we see at Jersey City is actually the community of the homeless and substance abusers, who are sort of in a little nucleus that communicate with one another. So you want to know who surrounds that patient. And then, how might I help you? And by recognizing that there may be spiritual distress, it means you can go and ask your chaplain to help you out with this particular patient. Chaplains play a vital role in palliative care teams, not only in caring for patients and families, but also, what I've seen over time, the chaplains tend to minister to us too, which is a very useful thing. Okay? And again, just recently, the Spiritual Care Association just launched a web-based curriculum for certification in different aspects of spiritual care. This organization uses evidence-based material, and it'll be exciting to see what happens. So again, spirituality, which in a sense, certainly in my training was pushed to the side, is really an integral part of caring for people who are sick. Okay. The next area, and again, I am going rapidly, but I think it's an important one, is care of the imminently dying patient. When I say imminently dying, it's the people we see on the floor who are going to die in hours, days, sometimes a week or so, but sometimes it's clear that they'll never leave the hospital, so to speak. In our country, most people want to die at home, but most people don't. And still in New Jersey, about 3/4 of the people who die in a health-related facility, either a hospital or a nursing home. People are living older. The older folks, the oldest are growing rapidly. And what I'm saying is this is an important epidemic we're facing now, is people are dying acutely in the acute care hospital. And what do? The signs of imminent death are multiple. Weakness, more sleeping, diminished intake are things. Confusion is almost universal. People have a low grade delirium, if not a robust delirium. Incontinence may occur. Hallucinations, sometimes of family or past events can happen. Diminished output. People have reference of returning home in a poetic way. You know, we had seen a man who was from Greece and kept saying, I want to go home. And you can't go to Greece. But he was talking about going home to heaven. That's a signal that someone may be imminently dying. And another thing we see at the bedside is when there's discussion around a patient of the good old days, where there's reminiscence of what had happened. So these things together don't diagnose 100%, but let you know that people may be dying very shortly. One question of what things are important when we die, what is this so-called good death? This has been researched. There are many, many factors, but one thing that always stands out for me is the people's desire to leave a legacy, to leave a mark on earth once they leave. Pain is management is important. People, of course, want to have clear thinking, and it's contradicted by the fact that most people, as they approach the end, lose their clarity. Not completely, but becomes a little slow, a little more confused. Where's Gwen? I'm glad she brought me 2 waters. Anyhow, this is from The Economist that just asked, from an economical point of view, what is important when you die? And this is just broken down for different countries. And what's striking is that people in Japan, about living as long as possible, is not as important as Brazil. But what it shows you, just the things that are important. The reason it's important to know these things is that once someone is gone, they've not been able to accomplish those goals. So if you are aware of what they want or need, you can institute that at the present time. It's important in the imminently dying not to forget them. So daily grooming, shampooing, oral care, care of odors, and osmosis is absolutely important until the very end of life. Now implanted defibrillators are so common, it's important to remember to turn them off as the end of life approaches. At the moment of death, it's a very sacred procedure. Pronouncing a patient is making the calls. But I think one of the most important things we can do is thank staff for the care they've given. And it's commonly nurses, but it's not only the nurses, it's all the people who've been around that person. Commonly people from dietary and housekeeping develop close bonds with patients and families. So thanking the people for the work that they did is, I think, very important. Funeral attendance is an option that comes up rarely, but at times you'll be directed as to whether or not attending a funeral is appropriate. Okay. In England, a fellow at Ellershaw developed a pathway for the care of imminently dying, and he developed a number of criteria to say, if Mr. So-and-so is going to be dying here, what is the best way to have him have a peaceful death? And these are a number of things. One is you review all medications and virtually stop all medications that have been given and use medications to relieve symptoms. This can be done commonly by a continuous infusion of 1, 2, or 3 drugs with a driver syringe, but also discontinuing fingerstick hematocrits or stopping rapid responses or the routine chest x-ray. You want to clean the slate and just focus on from a medical point of view, what pharmacologic agents you need to develop comfort. You want to have the psychologic insight. You want to know what the patient and family understand of what's going on, but also how are they being affected psychologically. And we sat with the family from Puerto Rico, whose large family. His sister was dying from renal failure, heart failure, clearly at the end of life. And it ended up that her 4 children are all developmentally disabled. And the worry was what's going to happen to these kids. So recognizing that particular aspect, the psychological or psychosocial aspects of the dying is very, very important. We talked about spirituality and religion. Again, the chaplain should always be involved with someone who's imminently dying, unless it's declined, but that's very, very rare. You want to make sure not only do we understand what's being done, but you want to speak to the stakeholders in the family. Do they understand what they're being told and what the plan is? And you want to be confirmatory there. And then, of course, the team, let the primary caregivers on the floor, the primary nursing unit know what's happening, what you anticipate, and what's been done. You wrap up by just making sure people understand it, and you want to know how each of us can connect with one another during that period. And while I was at Beth Israel, we had developed a pathway for the imminently dying and looked at it at an oncology ward and a geriatric ward, and it proved to be successful. And it was expanded to a VA unit in Brooklyn. What I'm saying is it's important to recognize someone is imminently dying so that you can get the right stuff in for what they need at that moment. And finally, I'm going to discuss what's going on in the world of palliative care. And the Robert Wood Johnson Foundation actually has been a major catalyst for the development of palliative care in this country. It's overlooked, but it's extraordinary. And 20 years ago or so, they gave out 2-year grants for palliative care. And of these 9 centers, all are now very successful, maturing centers throughout the country. And what the program did was prove that by investing money into a valid program, that you can get a good outcome. For example, at Mass General, which has a wonderful clinical program, it has become the really international center for graduate education in palliative care. Or if we look at Mount Sinai with Diane Meyer, they've developed a combined geriatric and palliative care department, but they developed an organization called CAPC, Center to Advance Palliative Care. I'll discuss that in a minute. So again, it's the importance of philanthropy in catalyzing this work. So CAPC is based in New York. Basically, their goal is to provide throughout the country all hospitals with the tools and advice they need to develop palliative care. And with it becoming popular and CAPC being 20 years old, they're now trying to integrate information that the administrative side of medicine is doing with what we're doing clinically. So for example, they're forming a foundation for state palliative care policy and activity. It's a long name, but what it basically says is people are doing lots of stuff in this country that hasn't been centralized. This is a way of centralizing all this information. The National Palliative Care Research Center is also based in New York. And I'm emphasizing the importance of research because not too many years ago, there was no research in palliative care, and people would say, what the hell are you doing, you know? But now there are clear tools that have been validated. And this organization is there to culture a generation of, I think they use the word young, but researchers into this particular area. And as an example, working with the American Cancer Society, 4 grants were given to these groups to develop different programs. One is a very interesting one about couple-based mediation for lung cancer patients and their partners. We all know the devastating effects that cancer pays on a patient family. But at the very last last one is looking at a minimally invasive cordotomy for refractory cancer pain. In other words, there's some tough pain problems that need specialist advice. This is the kind of research that'll let us know what may be beneficial. Okay, I have 4 minutes. I think I can do it. The AHPM is the American Academy of Hospice and Palliative Medicine, and it's the really the only organization that represents physicians in this country that do palliative care. And its core mission and core purpose are very clear. The idea is to deliver easily high-level palliative care throughout the country. It does it by many tools, education and growth. In education, they have national meetings. The last was held a few months ago in Atlanta with about 4,000 people, where people have all kinds of learning experiences, can exchange their research data and so on. It's a large number of web-based things, and if you're looking for MOC points, you can check their website, and if you're interested in palliative care, they can walk you through a number of topics. In terms of growth, we know that there's no money in palliative care. So what the organization does, it has funds that have come from philanthropy that is used for example, programs that are in more isolated areas, or for fellows who don't have the money to continue fellowship training. And just going over to Europe, the European Associated Palliative Care is different from our organization, that it includes all members of the interdisciplinary team, and it also has organization members and individual members. It does a lot of good work, and I'll jump quickly because its biannual meeting is held in Berlin next week. And their main topic is to look at global palliative care. How do you assess what's going on in the world? How do you disseminate the information? And they're focusing on, and we didn't talk about this, about the importance of volunteers in hospice and palliative care. And they're going to be having a working group to put out a statement about the importance of volunteers in this work. The International Association for Hospice and Palliative Care main goal is to deliver the tools needed to develop palliative care in needier parts of the world. This is based from Open Society Institute money, but now gets money from philanthropy and so on. It's really a wonderful organization. It's also, if you're interested in palliative care information, this website produces a bi-monthly newsletter. It does book reviews and has resources for many books and journals if you're interested. And just an example of the grants that they give. This is a woman in Guatemala in an isolated part who got money to start up a palliative care program for kids. In Haiti, which is a very close neighbor of ours, a team from Tennessee came down with a curriculum and taught it to people in Haiti. And finally, the World Health Organization is involved with implementing palliative care. There are a number of things here, for example, implementing palliative care in areas of strife where there are humanitarian crises like Yemen, Syria, and so on. It has to do with pediatrics. And I think very interesting is integrating palliative care and symptom relief into primary health care, because this is going to be the moving force of palliative care in the future, our primary care people. And I'll end with where we started, with the definition of what is palliative care. And this is a painting I'd seen in Amsterdam called The Sick Child. It was painted by one of those great Dutch painters from Rembrandt's area, painted during a time when there was a plague epidemic in the Netherlands. And what we can see in this painting is a young boy who's quite pale and sick. His eyes are googly, but we see quite a matronly figure. It could be a mother, a nurse, a nun. She has a little pot of soup or something there, and she's caressing him warmly. There's a warm light in the room, and the black, you can't see it from here, but that black object on the wall is a crucifix. And when I think about the definition of palliative care in words, and I look at this is what palliative care is. And each time I look at the painting, it gives me an essence of what it is that we do. So I'm going to stop right now. It's 1 o'clock. I appreciate your patience and your time. And certainly if you have any questions, I'll be happy to stay around.
RWJBarnabas Health. Let's be healthy together.